Hi there, it's Dr. Steve Cohen, plastic surgeon in La Jolla, California, and a clinical professor of plastic surgery at the University of California, San Diego. I am delighted to invite you to Face by Fats. This meeting will be held in Bangkok, January 16th to the 18th. We will have a cadaver lab in the beautiful new facility at one of the leading universities in Bangkok. I am thrilled that the co-speakers will be one, Mike Nyack from the United States, and two, Francisco Brava from Madrid. Both of these surgeons, along with myself, will focus on the face, deep plane facelifting, contouring of the deep neck, brow lifting, regenerative applications, and the latest and greatest in face surgery. This will be one of the best meetings in Asia, if not the world, and I hope all of you will attend and join us at the middle of January, the 16th to the 18th in Bangkok.
Hello, this is Francisco Bravo from Madrid, and I just wanted to share with you that I will be participating at the Face by Fats meeting in Bangkok, Thailand, next January from the 16th to the 18th. I will be going through my techniques for face and neck rejuvenation, talking about deep reduction, dual plane neck lift, and of course I will be going through my direct deep plane facelift technique, as well as other techniques for facial rejuvenation such as eyelid procedures and lip lifting. On the 18th, I will be able to showcase all of these procedures through a live cadaver workshop, and I will go step by step talking about the different parts of my techniques for, again, face and neck rejuvenation. So again, I really look forward to seeing you in the Face by Fats meeting, Bangkok, 16th, 18th January. Hope to see you there. Take care.
This is Dr. Nyack from St. Louis. I am so pleased to invite you to join me at the Face by Fats meeting January 16th and 17th in Bangkok, Thailand. On the 18th, we will then have a cadaver lab. On the lecture section on January 16th and 17th, I'm going to go over my technique, my personal technique of deep neck lifting, deep plane preservation extended facelifting, brow lifting, blepharoplasty. And then again on the 18th, I will be showing you exactly how I do it in the cadaver lab, and you'll get your turn to practice. I really hope you can join us. It's going to be a fantastic educational experience, and I'll see you in January in Bangkok.
Okay, a very good evening to the participants for today webinar, where we are very happy and honored to invite Dr. Kamol Wattanakrai, a plastic surgeon from Thailand, Bangkok, and also my dear friend Mr. Lee Kim Sia, a very distinguished plastic surgeon from Malaysia. And before I start introducing Dr. Lee Kim Sia and most of the participants, as you can see, the video from the Chulalongkorn University, the cadaver lab. This is actually the pride of Bangkok, Thailand, to have such distinguished, nice facilities where they have about 24 stations and is fully renovated, brand new. Okay, and I just came back last week from the lab, and it can host up to 200 participants in the lab. This is actually a pride, for Thailand. Okay, without further ado, let me introduce my very best friend, Mr. Lee Kim Sia. He's a British trained plastic surgeon from Penang, Malaysia, with over 28 years experience as a consultant. A graduate of University of Malaya, 1986, he earned his postgraduate diploma in general surgery from the Royal College of Surgeons of Edinburgh, 1990, and his diploma in plastic surgery from the Royal College of Surgeons of England, 1996. Renowned for his expertise in fat grafting to the face and breast, Dr. Lee pioneers stem cell enriched fat techniques and combination implant procedures for enhanced results. A sought-after international speaker, trainer, and live surgery demonstrator, he has held key leadership roles, including founding chairman of the Asia Aesthetic Breast Council and past Secretary General of the Malaysian Association of Plastic Aesthetic and Craniomaxillofacial Surgeons. He currently practices at the M Clinic in Kuala Lumpur and Penang, served as an associate consultant at several hospitals, and is a senior faculty member and research trainer with Elegant Medical Institute. So without further ado, I pass on the room to Mr. Lee to introduce Dr. Wattanakrai.
Thank you, Eddie. Can you hear me? The voice okay? Good.
Yes.
Thank you. Now, Dr. Kamol Wattanakrai is a good friend, and I know him for a long time, and obviously a senior to me, and one that I learned a lot from him before, and now obviously he is a board certified plastic surgeon since 1985, before I even graduated as a doctor, and founder of Bangkok Skin Plastic Surgery Center. And he held many positions before this, and among these, the chairman of the Department of Surgery at Bumipur RTH Hospital, president of the Oriental Society of Aesthetic Plastic Surgery, and Society of the Aesthetic Plastic Surgery of Thailand, and National Secretary of ISAPS. Currently, he sits on the board of directors in the Rhinoplasty Society of Asia and advisory board of the Plastic Surgery Societies, and is widely published on his work, including innovation in eyelid and facial rejuvenation technique, and he has earned multiple honors. Now, the one that I like to highlight, which is also today what his topic of presentation is, the one that being awarded the 2024 PRS Best Paper Award. And Dr. Kamol is obviously very, very well versed in this technique. And I believe he's done thousands of eyelid surgery. And one of the problems we face in especially is done by some untrained personnel and even non-medical personnel, is what among the problem would be the very high fold, very unnatural looking eye, which is not suited for our Asian face. And this creates a lot of problem. And the technique to correct this problem can create multiple problem as well. So it's my great honor and to listen to him and on his method of um, uh, try to solve this problem that we always face in our practice. Dr. Kamol?
Thank you, Kim Siem, my dear friend. Okay. Today we talk. I'm pleased to talk about my experience in correction of the high eyelid folds. Thanks, Kim Sia, for you have emphasized the importance of the uh, high eyelid fold. The correction is not simple. Sometimes the inexperienced surgeon can cause even when you do the try to revise this, the high fold, sometimes you cause more trouble. So be prepared to be well knowledge for your the procedure that you're going to done. It's not easy, not straightforward. But today I will share with you. May I have my first slide, please? So I'm going to talk about the the topic
Uh,
that I present. And
you
can you
need to
see my
share the
slide?
screen, please.
Can you see?
Okay. Yes, yes.
It's okay. I'm going to talk about the topic that I published in the PRS, the algorithm for correction of the unaesthetic high eyelid folds. This is a topic that I'm luckily I got the 2024 PRS Best Plastic Cosmetic Surgery Paper Award. My article published in 2023 and got the 2024 Best Paper Award in San Diego last year. What you want to know about the unaesthetic high eyelid fold? What it is? The fold that is higher than general perception in a certain population. It's not like how many meter is unaesthetic. It's not because it varies between Caucasian or Western people and the Orientals. So in our Asian, sometimes if you a high fold maybe 9 millimeter, some consider uh, too high, but for the Western, it is a very aesthetically pleasing high fold. So we should understand the high fold. What is considered too high eyelid folds? We consider the tarsal height. Normally, the tarsal height is about 9 or 10 millimeters. In Asian, the fold that originates above the tarsus uh, can create a sunken look, so it looks so tight eyelid, so it's not like a aging person, so it's not preferable in our Asian people. So we're going to learn the cause and prevention of uh, the high fold, maybe the too much skin and fat removal, or maybe the improper design, because the surgeon try to imitate the eyelid of or sometimes they train in the Western country and to try to do the same surgery. It not create the aesthetic looking for Asians. And the sunken eye and anastomosis is another cause of the high fold. So what we will cover today is the brief outline of the high fold cause and prevention. So we missed the slide that, and you understand the treatment strategy, why and how, and then you knowing the difference, underlying pathology, and select a proper procedure for each group. Then you can learn the algorithm. So the cost of high fold depend on the experience of the surgeon. If you are the beginners, maybe that I mentioned before, too much skin and fat removal can be the primary cause. When you go in more experience, you try to create some difficult case, and you try to design the like the Western eyelid. So improper design may be the cause of the intermediate surgeon. Even though you are the experienced surgeons, you can have the problem if you deal with the sunken eyes and anastomosis. For the sunken eyes, if you try to dissect too much over the sunken area, you can cross the higher fold than you expect. And anastomosis, I will mention later. So we have to learn about the traditional high fold revision for most of the surgeons do. It is a skin excision technique. Even though they try to advise any technique of the suture and the release, and if most of them using the have to excite the skin from the between the from my point of view between the previous crease line and the new crease line. So they have to excite this most of the case. Okay, but the drawback of this skin excision, we have to learn this. On my left slide, you can see that this is when you create. This is the previous fold, And this is a new fold that you create. When you create a new fold in the lower part, and you excite the skin from this portion, and you set the new fold that you set it quite 7 minutes or something that you satisfied. But when you close the wound, close the excised skin, you either pull the pre-tarsal skin, it be longer or higher than 7 millimeter or 6 millimeter that you intended to have. And then even you fix it quite strong to the pre-tarsal fascia. You said to fix it at the 7 millimeter, but sometimes when you close it, the upper skin fold will draw back, and the skin fold will be less. You have less skin to cover the fold. So eventually, the fold will be higher than you expected. So I introduced the idea of preserve the skin between the new and old crystalline. This is the main principle to provide ample skin. You have the ample skin to cover the folds. So we will not excite the skin at the beginning, but at the end of surgery, if we have ample skin enough, we can excite skin later on. So, but with this technique, people mention and then criticize that is two lines blepharoplasty, because you can have scar to scar on the upper eyelid, and sometimes you end up with multiple folds or triple folds. So my technique, we have to prevent triple fold and the double scar formation. The first one is the meticulous dissection to clear all adhesion. It's not a straightforward. You need some experience to clear all adhesion. And also with some difficult case, you can have the differential dissection that I will mention later on. So, but the fat grafting is also indicated in my cases. But the elevator advancement is the trustworthy tool. That's the most important thing that I use in all. I try to do it in all my case of high eyelid fold correction. So the question is, should we do an advancement? The answer is yes, because I think the high fold ptosis are very common than we might expect it in Asian patients. And also, they have the trend of bigger eyes in the Oriental. They want eyelid palpable feature wider, like a Western patient. So you can see, look at all the patients that come to my office. Most of them didn't look for, they have not asked for any ptosis at all. They asked for the high fold correction. But all these cases, even especially this gentleman, you can see they have a ptosis, typical ptosis, but they have a sunken look, they have a high eyelid fold, they want to correct the high fold. So this is a ptosis patient, and also in this also. So all of these cases, when we do the elevated advancement with the high fold correction, they end up from the upper part here, the high previous surgery, and then you can correct the high eyelid fold. This is also the same patient on this right and left. Actually, on the left side, you can see that just the ptosis correction, and also you can see the patient from the beginning, and nowadays, after correction, it looked younger, and also the high fold was completely correct. So the second reason that I need to do the development is the trend of bigger eyes. For example, in this case, she said she don't want her high eyelid for sunken look. So I asked her that if you have a little bit of a higher of the palpable vision, eventually she didn't have any ptosis, but she happy to have if it wider a little bit. So we do the high fold with slight elevated advancement, not too much. Okay. This is the pre-op. You can see the pre-op and the 3-month post-op. And also the third reason to do that is you can imagine the direct effect of advancement. If you just increase the height of the palpable feature up a little bit, you can gain reduction in the fold size from here to this. It eventually, even you didn't do anything, you're just doing the advancement, the eyelid fold will be lower because of the advancement. And then the fourth reason is to prevent readhesion. Because when we do the high fold correction, we have to dissect the previous fold on the left slide. You can see that this is the red dot is the previous fold. And when we try to, we just dissect up and release it. And then because we didn't excite the skin at the other surgeon, so it may be relapse and maybe readhesion again. So when we bring down the levator adhesion point down to levator advancement, the adhesion point will separate together, so it can prevent the ligament fold. This just to show you another reason. Reason is the strong vertical lift against the inward collapse. You can see that on the left side, if you have let the levator with the same power, maybe one arrow or one arrow, the same the same strength. Okay, you can have maybe the patient look up, you can have the collapse of the previous fold. But if you increase the power of the vertical lift, it can prevent the inward collapse. This is the 5 reasons that I think I try to do the levator advance in every case. So this is the I can show you. This is the slide is to show you how I do the levator advancement. This is at the real-time surgery. After starting doing the levator advance here, from here is the real-time surgery, because I want to show slowly because I talk about this topic many times. People always ask about how you dissect, how you do the levator advancement. So this is the real-time surgery. When in any case that you can do the levator advancement, you see in this case we dissect directly from the lower fold down to tarsus vertically, and any tissue in between we can remove it to expose from here, and expose the pretarsal fascia or the tarsus that is strong enough to hold the levator aponeurosis. This is the levator aponeurosis. So if you don't dissect this clearly, sometimes when you attach the levator aponeurosis, it can be relapse at all. But when we do the differential dissection in the later of my talk, we have to preserve all the tissue. Okay. So when we completely dissect and identify the levator aponeurosis, we start doing the levator advancement and plication. And see, I prefer to start from the medial side of the eyelid first, not the central part that many surgeons prefer to check the height of the eyelid first. The reason is that, as in my experience, I think the levator aponeurosis on the medial side are less robust, maybe sometimes thinning or not so strong, sometimes cannot pull it as good as the central and lateral one. So I start the medial first and check the size of the eyelid aperture to see whether it is enough. Then when we go on the central and lateral to make the curvature of the upper eyelid to be as natural as possible. Okay, this is the first note. After my talk, if you can look back to the some paper or some article about the ptosis surgery, if you try to you observe the outcome, the pre-op and post-op, that the people using the central stitch first, most of the case you can see sometimes they have a peak of the central peak of the eyelid after ptosis correction. That is because when they start with the central at this area, the central first, to check whether they have the amount of advancement enough. But when they have enough of advancement, they cannot do on the medial part to achieve the desired lift of the eyelid as the central part. So that's why I prefer to do the medial first in all my case. And on the lateral part, it also follow the central. Every time when I do the surgery, the patients have to be under local anesthesia and have to look up every time I put the stitch on the tarsus, or even though I set the fold. So the patient have to look up and down all the time after the key stitch. And also this is also the lateral portion. You can see the attachment on the tarsus is somewhat important. You can use the partial thickness of the tarsus or some people use the pre-tarsal fascia is enough. But before you going on tie it up, you have to check that this the suture on the tarsal is strong enough. If not, you can have end up with the recurrent. This is the end of the surgery. Okay, and then after we do the levator advancement, I set the fold, the eyelid fold later on. When I in the case of secondary case, because you can see we didn't mention before that the fold from 10 to 8 millimeter. So when we want the 8 millimeter height to be fixed, I have to fix up the pretarsal fascia to fix the fold. And also I do this maybe even in the primary case. Sometimes I prefer to do the pretarsal fixation skin and also levator that we call the 3 points fixation. That is, fix the skin or muscle underneath the flap, and then the pretarsal fascia, and then the levator aponeurosis. Because if we fix to the levator aponeurosis only, that many authorities suggest that you can prevent the static lines, but I don't think this can cause the static line. I think if we fix only the levator aponeurosis, it is the elastic tissue, and also sometimes the size of the fold will not exactly as you want. So normally, I prefer the three-point fixation in this, especially in the high fold that we want to fix the new fold to the intended that we want, the size that we want. Don't want to slip away or higher than we want. And this is to fix the skin excision. So this is so the levator aponeurosis is the surgery that I have to do. I want to do in every case. I try to seek to ask to see for the ptosis and ask the patient if they want to do the levator advancement or not. If you want, okay, I will do going on. Many paper that quote that refer to my article, they also said that I I do the correction of the high fold with ptosis. Actually, even though they have no ptosis, I try to do the levator advancement, not because the patient come to uh, my clinic are all the high fold with ptosis, but they have the people who come for high fold, and I ask them to and try to find any chance to do the levator advancement to increase her eyelid fold. Okay, this is her immediate post surgery and her before surgery. Okay, and then for the levator advancement that I told, as I mentioned before, it's not a straightforward procedure. If you do inadequate correction, you can have relapse, or you can end up with triple fold that people are aware of to have to excite the skin. But if you do the too much, you can end up with the upper eyelid retraction. That is a serious complication that difficult to correct. I show you some of my case. This is a case that have to multiple fold, high eyelid fold, have to multiple surgery 2 or 3 times. The second surgery is by myself. I correct her eye fold, and then she said it's too small, and she go to another doctor to do the surgery, and then she come back to me, end up with this severe than before. So I do they have to do the ptosis, levator advancement. That is 1 week post surgery. It looked nice. It looked acceptable. But when she came back to 1 month post surgery, you can see that they have an upper eyelid retraction. So we have to do another surgery. Actually, we have to do 2 surgery for her. We call the levator recession. To release the levator downward, it's not so easy. So this is the 9 month post surgery that they have to say. 9 month post surgery, post revision. So how to prevent the eyelid retraction is to the answer is to careful advancement in ptosis patient, and in non-ptotic high eyelid fold you have to avoid elevated advancement. But you have a question now: is it effective in high fold correction to prevent the scar on the triple fold or not? So we have to develop another technique to when we cannot do limited advancements. That is called the differential dissection to prevent upper eyelid detection. Because the dissection is to prevent upper eyelid detection for unnecessary advancement. So with our elevated advancement that I said, it's very valuable tool to correct to prevent triple fold. We can have possible the adhesion or triple fold. So we need to have another procedure we call the augmentation procedure under previous scar, maybe the fat graft. We call the septo-aponeurotic sling that I will show you later on, and the local soft tissue flap to all the procedure to augment under the previous scar of the upper flap. Okay. Also, the differential dissection that I'm going to show you is the procedure that we preserve all the tissue to augment the upper flap. This is the presentation of we have to preserve all the tissue. I have the slide to show you later on. This is an animation to show you that we have to differential dissection. First, we dissect on the lower flap, and then we remove all the tissue to the upper flap. Preserve all the tissue upper flap to augment it. And then after that, we dissect under the muscle and tissue, and then we they open the new window. So the attachment here is the aponeurosis extension to the fold. So if we have this, then we turn down the aponeurosis. We can have some length of the aponeurosis here to prevent upper eyelid detection. So this to show you a video will be easier for you. This patient, you cannot do because the right eye, you cannot do the elevated advancement because they have some upper eyelid detection. So we have to do what we call the differential dissection technique. The same as the elevated, we have to dissect vertically around the lower flap area down to the pretarsal fascia. But in this technique, we will not remove any tissue on this. We try to preserve all the tissue from this and to bring it up to the upper flap. So with this, when we dissect here, and then after we dissect some tissue up, we open the orbital septum on the lateral pass, and then we try to identify the area of the adhesion. The area of adhesion is the area that the extension of the lateral aponeurosis to the fold area, to the crease area. So that is the area that we have to do the dissection. This is to locate the level. This is the fold adhesion in my point on the toothpick, and then we draw this is the tissue above this. It have to be dissect to all here to the upper flap to augment to prevent the adhesion on the upper fold area. So we dissect. This is my early case, so I dissect not so far to the upper tarsus. Actually, we have to dissect a little bit more before we go into the lateral pocket. Anyway, this is a safe procedure when we dissect, and we think we come very close to the area of the levator extension to the fold area. So we should dissect, cut this area, cut this from the above. If we cut from below, you injure to the levator aponeurosis. So we decided to cut from above to down here. If we cut from here, it maybe you cause you can cut an aponeurosis. This we dissect to clear adhesion up to. So we show you we come back to the lateral pocket and come down, and we release the adhesion, the same adhesion down. We release it down to the lower flap. So you have this area. You can see the muscle here. Even if it's track, you can see the muscle that can be preserved to the upper flap. This is like the local soft tissue flap that to augment the previous scar area. This also we cut down to the lower flap to preserve the muscle. after we complete release, we go on the in this case we set fold to the tarsus first because she had upper eyelid retraction. So we want to fix the lower fold to firm enough to prevent retraction distraction upward. So then we fix the levator to the tarsus, not to now we fix to the tarsus only. And then after levator fixation to the tarsus, we fix the levator. This is some area of the extension that we got from the differential dissection. If we don't have this tissue, we have to move the levator downward a little bit to the fold area. So you have sometimes have upper eyelid detection. So this technique we can prevent the upper eyelid detection. So not all the cases that have to do what we call the septo-aponeurotic sling. The technique is that, oh, sorry. Okay. Okay, I touched it. Sorry. Yes. So we pull down the fat, sometimes with the orbital septum, the superior anterior surface of the orbital septum, sometimes with the fat, or in this case we pull only the fat, and we fix it to the remnant of the levator aponeurosis at the lower fat. So it can create the fat that can as a lubricant, a space for gliding of the lower fat upward to prevent the adhesion. And then we do the lipofilling also in some case. This is the immediate post-op, post-surgery. This is pre-op. And this 9-month post-surgery. You can see no scar at all even we leave the previous fold. No triple scar that people are aware of. So I will explain to you a bit about the septo-aponeurotic sling. You can see that we have this when we advance levator down to the tarsus, we have remnant of the aponeurosis here. Instead of remove it as many people do, we turn it back, suture it to the orbital septum or also to the fat. It can create the normal fat tissue underneath the skin. So to prevent the adhesion of the previous fold, this is the septo-aponeurotic sling. So look at some of my case. This is the case that you have upper sunken and the upper eyelid fall too high. This is a fifth day post-op, and also this is a 5-year post-op comparing to the pre-op of the correction of the high fold. And also this is the more severe. You have to see the upper eyelid retraction, a bit retraction, and also the eyelash eversion. This is you can get more advantage of the benefit from the differential dissection because you have to release the levator downward. So you need to have some tissue extend from the levator. This is the before, and this is a 7-week post-op. Another case, this is the most severe. You have to see that the eyelid detection and eyelash eversion. So the same technique with the differential dissection. And this is the 1-week post-op. And also this is the 9 months post-op. So in summary, we have introduced the high fold correction by skin preserving technique. We use by the levator advancements or differential dissection, and also some adjuvant procedure. And why we have to summarize the algorithm for you a bit because we have three main different aspect of the patient who come for the high fold correction. Okay, you can see you can have the first one, the left side is the no ptosis, and the right side is with ptosis, and also with the subclinical or borderline ptosis. They have three types of these for ptosis. So if the patient come with ptosis, it's easy. You have to do some simple release and do elevator advancement, and then you can set fold and set fold, and this is a complete correction. But if the patient come without ptosis on this, you can do the differential dissection, and though you can set fold and also the skin excision on this and on the elevator we decide it later on. If you have if the previous surgeon didn't excise too much skin, you can you can excise skin for to have a proper size of the eyelid fold. Okay, but sometimes if you don't do the limited advancement, you can have a chance of incomplete or possible recurrence of the adhesion. Also, with even you do the ptosis in sunken eyes, you can both scenario you can have have a chance of relapse of the ptosis. So you need some of the augmentation of the upper skin flap. This is the local soft tissue lipoprotein. But if the subclinical, you can come with this. You have a patient to have choice. Request the patient if you want to have the eyelid wider palpebral fissure. If she want it easy for us to do the elevator advancement, the same procedure. If she don't want to change her eye size, we do the differential dissection. So before I stop, we have to we have some suggestion to you to read my paper on in the August of 2023 PI's paper. If you have any question, you can ask me later on. Thank you. Thank you very much.
Thank you very much, Dr. Kamol, for the great presentation. And right now, we are opening up the floor for question and answer. So you can raise your hand if you want to ask questions or chat or put in the Q&A. Mr. Lee, maybe you can start moderating. Yeah.
Yeah. Okay. I didn't see any question yet.
Mm.
Maybe I should start the ball rolling. Now, thank you for pointing out there's a high flow problem. I think a lot of the surgeon, whether plastic surgeon or untrained personnel, when they do a double eyelid, very often they overlook the problem of ptosis, and this is probably a major problem. If you correct the ptosis, most of the time, the high flow problem will be minimized.
Mm-hmm.
Um, that's what been pointed out by Dr. Kamol.
Mm-hmm.
Now, Dr. Kamol, your ptosis collection, how much advancement can you give a guide on depending on what will your guide be, the severity of ptosis to how much advancement that you actually shorten or pull down the levator?
This is a great question. Thank you. I often be asked by many audience when I present this, but actually that is why I have to do under local or some kind of IV sedation. I ask the patient to actually uh I estimate the degree of eyelid upward aperture a bit before surgery, but exactly the the decision making is on on the table when we do the surgery advancement. I have the patient to look upward. That's the main point. We don't have a solid complicated numerical at 1 2 min 2 minutes 3 minutes. It's not. So we critical adjustment to look at the patient upward and do the comparing to the previous. If you have they have two ptosis, and when do on the one side we going on and we check if it some improvement. Actually have some improvement is okay. Not try to do so much. At my early experience, I have quite a problem about the advancement. We cannot do advancement. We cannot pull the eyelid upward. But nowadays we are afraid about the too much advancement. We can do advancement, so we have to try to be careful. Just uh, try to suture to the tarsus and then let the patient look up. And then if it has some advancement and some wider of the eyelid, so that is okay. Try to be conservative first. Okay.
Yeah,
Mm.
I tend to follow this approach as well, Dr. Kamol.
Mhm.
patients opening the eye. Now, I
Mhm.
think some time ago, Dr. Chin Ho Wong published a
Mhm.
paper on, how many millimeter to to
Oh,
advance. I find it a bit
yes, yes,
complicated and difficult to
yes, yes,
follow. And
yes.
have you seen the paper, Dr. Kamal?
Oh, I heard about it, but not truly under, not. But I had a lot
Mm.
of paper about
Yeah,
calculation of this. I think it don't it. I don't think it can be a valid procedure for beginner. I don't think. I think the clinical, you just add the guideline is okay. Add the guideline, and they have to check the clinical. But for the ptosis, we don't want to. It not for the high flow correction. If the patient don't have any too much ptosis, not we just want the elevated advancement to correct, to prevent the triple fold. We don't want there to over like the ptosis patient. So just if we if we just improve the eyelid aperture, it's okay. Try to be conservative, because the eyelid detection, if you going on like a numerical status that uh, 2 millimeter advanced had 4 millimeter dissection of the aponeurosis. Sometimes if you got the upper eyelid detection, it's very difficult. Even in my hand, I think it's very difficult to correct upper eyelid detection than correct the ptosis. Yeah.
yeah, that's true. I recently had to do one, my own work.
Yeah.
Yeah. Hey, we got a question here. Do you combine these techniques with brow repositioning in the same operation?
Normally, I don't but if in some particular case on the lateral brow, sometimes I do. But normally, I think if the patient have ptosis, if we correct some ptosis, the brow will drop a little bit.
Hmm.
Uh,
Yes.
yeah, so I if we do at the same time, I do just only the lateral part to elevate the lateral part of the eyebrow. We do the sub brow sometimes, sub brow rib only on the lateral part. Yeah.
Right. Right. Now, the other question I have is, your high fold, it can be 13 or it can be 11. When you make your choice of your height of your fold that you intended to cut in size, what would be the guideline be? Let's say a person with a 13 millimeter fold and the other one with 11 millimeter. Which level will you go?
Oh, this is also a very great question. Also, you are experienced surgeon. You choose moderator than correct like moderator, because in my paper we have normally I when we have the skin gap between the the previous fold and the new fold. I do suggest not more than 3 or 4 millimeter when you want to drop down. For example, it, if it to maybe it to exaggerate, if the patient have 14 millimeter sometimes, for example, did it exaggerate 14 millimeter? We don't not come to 9 millimeter. We cannot do. We need to do the new fold should be maybe uh, 11 or 12 millimeter. That is the solution. Not if you should not leave the skin bridge between the two fold too high, too wider than 3 or 4 millimeter. Sometimes you can. I think my article mentioned about this also. Yeah, and because if you uh, so we cannot rely on the fat injection only, but for the local soft tissue fat, like the differential dissection uh, have may help a lot. And when you have the gap too high, we cannot have the soft tissue to augment underneath. So, but for the fat injection, it not so reliable, but it's helpful. Also, yeah. So you should not uh, leave the gap too wide than 4 millimeter sometimes.
What is your experience in collecting a triple fold or double fold with fat graft alone? Let's say patient has no desire to have any more
Yeah, triple
surgery.
fold or multiple fold. The cause is the adhesion above. Sometimes it's because of in the sunken eyelid, even the primary blepharoplasty. The sunken eyelid when you dissect unnecessary dissection above. When we do the sunken eyelid, do a double fold eyelid fold sunken, we try not to dissect too much above the area we want to have the fold. Okay, try to minimize. If you dissect a lot up, you have no fat to be in between. You have a chance of the extra fold that you didn't intend. You didn't suture it, so you have upper fold. So if you got the triple fold, the problem is some adhesion, so we have to go and release. When we do release it should do release it completely to completely release it, to have to check the patient, look up and down. Even before you finish the surgery, when you crossing the wound, if you when you have some like some sunken area, like the triple fold may occur, you have to release the suture and do releasing again, and then we do everything to prevent it. We do release it completely. We do the septo-orthodontic sling if the patient have some fat, and the last choice, and the last thing we have to do the fat injection also. Fat injection, because when we do fat injection to the supraorbital rim, you can see that we can ballooning of the tissue up a bit and can prevent the adhesion downward. That is the procedure that I did. I also do. Yeah.
Which precise plane that you inject the fat?
The plane I do you know, first we have to inject on the supraorbital rim, not in the orbital septum, which is try not to do. We have to supraorbital rim and the inferior border of the supraorbital rim, prepolar ostium, submuscular, sometimes. Yeah, yeah. That is the
Mm.
plane, because if we inject into the maybe people may think we inject to the replace like with like some for the concept. We have to inject fat into the orbital septum underneath to replace the original fat. But actually, when we inject into that, you compromise the levator function. The patient will have ptosis. After sometimes maybe even it temporary, but sometimes it very long time. Patient will complain a lot, and when you have mitosis, the high flow, you cannot correct the high flow. Yeah.
Yeah. What about putting some fat in the muscle itself, particularly oculi muscle itself, to right in
It
the
can,
fold
it can.
itself?
I think it can also, but the concept of the putting the fat to prevent the triple fold is to ballooning the tissue of the upper fat, ballooning up. So if we press it in the muscle itself, it may be we should go under the muscle, the lower body of the muscle, going into the muscle. I think it not work for prevention of, but it can work for sunken eye sometimes, but it don't work for to prevent the relapse of the triple fold. Yeah.
Yeah. So very often we find some pockets of fat at the lateral aspect near the orbital rim. Sometimes you can actually move the fat across. So that's sometimes even in a secondary surgery, these fats are not removed. And so I find it quite useful in this
Yeah,
aspect, the moving transfer
you,
across. Yeah.
you call the fat transposition from the lateral to medial,
Yeah.
right?
Yes.
Yes, it
Yes.
is. It work also. It work also, but not in the sunken eye. I also use that technique also, but nowadays I think it not so. It can help some in some not so sunken, but in
Mm.
most of the case. Uh, so the concept that you try not to remove the lateral fat, that is the concept of the experienced surgeon. Yeah,
Yeah.
we remove, sometimes we transfer to that. In some primary case, I do also. Yeah.
Yeah. Okay. That's great. That's great. Thank you so much. I learned so much from you from this
Yeah, thank
paper,
you.
and it gave me a bit more emulation to tackle my patient that I see with high flow. Um, Eddie, any other questions? That you mute your Eddie, you mute your. I can't hear you, Eddie. You mute your speaker.
Yeah, I think we have answered most of the questions, and we are coming to about time, and yep. Are there any more questions from the floor, or we will let our two gentlemen go because it's quite late over this part of the world.
Yeah.
So if there's not much, no more any more questions, thank you, Dr. Wattanakrai and Dr.
Mm.
Lee,
Thank you.
and have a safe trip to your traveling again, Dr. Kamol.
Thank you.
You have been traveling a lot nowadays. Yep, yep.
Okay.
Yes. So
Thank you.
with that, as you know, the upcoming FATS by FATS, the face on January 16 to 18, we are actually very honored to actually welcome most of the faculty on the page. And as we always say, the three speakers are very rare, especially Bravo, Kohan, and Nayak to come at the same time. And I'm very lucky to have invited them. So we hope the participants can take this opportunity to meet them in Bangkok. So without ado, and these are the topics that are going to be discussed. And in particular, I can't say more and more times that the facilities in this university are really the pride, I would say the pride for Thailand to have such a great facilities. And thank you to the government of Thailand invested so much money to support the medical teaching in Chulalongkorn. So with that, thank you very much and good night. So this
Thank you.
Sure,
yep.
thank
Thank
you.
you very much, Dr.
Bye.
Kamo. Doctor,
Bye.
very
Take
much
Thank
care.
you.
Bye.
good.
Bye. Bye.
So very
Bye.
much.
Hi there, it's Dr. Steve Cohen, plastic surgeon in La Jolla, California, and a clinical professor of plastic surgery at the University of California, San Diego. I am delighted to invite you to Face by Fats. This meeting will be held in Bangkok, January 16th to the 18th. We will have a cadaver lab in the beautiful new facility at one of the leading universities in Bangkok. I am thrilled that the co-speakers will be one, Mike Nyack from the United States, and two, Francisco Brava from Madrid. Both of these surgeons, along with myself, will focus on the face, deep plane facelifting, contouring of the deep neck, brow lifting, regenerative applications, and the latest and greatest in face surgery. This will be one of the best meetings in Asia, if not the world, and I hope all of you will attend and join us at the middle of January, the 16th to the 18th in Bangkok. Hi there.
Hello, this is Francisco Bravo from Madrid, and I just wanted to share with you that I will be participating at the Face by Fats meeting in Bangkok, Thailand, next January from the 16th to the 18th. I will be going through my techniques for face and neck rejuvenation, talking about deep reduction, dual plane neck lift, and of course I will be going through my direct deep plane facelift technique, as well as other techniques for facial rejuvenation such as eyelid procedures and lip lifting. On the 18th, I will be able to showcase all of these procedures through a live cadaver workshop, and I will go step by step talking about the different parts of my techniques for, again, face and neck rejuvenation. So again, I really look forward to seeing you in the Face by Fats meeting, Bangkok, 16th, 18th January. Hope to see you there. Take care.
This is Dr. Nyack from St. Louis. I am so pleased to invite you to join me at the Face by Fats meeting January 16th and 17th in Bangkok, Thailand. On the 18th, we will then have a cadaver lab. On the lecture section on January 16th and 17th, I'm going to go over my technique, my personal technique of deep neck lifting, deep plane preservation extended facelifting, brow lifting, blepharoplasty, And then again on the 18th, I will be showing you exactly how I do it in the cadaver lab, and you'll get your turn to practice. I really hope you can join us. It's going to be a fantastic educational experience, and I'll see you in January in Bangkok.